after 48 hours, they started to see that the crack is just decreasing, like it's just healing. Is it really possible? But it is possible. Like how there is a crack healing mechanism in the bone, there is also crack healing mechanism in the tooth. When I start to learn about cracks, actually the studies were not from dentists. They were fracture mechanic engineering that they just studied about the crack. And nowadays there is a new system. It is called quantitative percussion diagnostic. QPD. There is a stress concentration in that point where the crack is starting. So we have to distribute the stress in that place, in that plane. That is the important one. If we're just going to remove the crack and putting the restoration on it, I'm afraid it's just going to happen again.
Over the years, we've had some awesome episodes on crack teeth. Like if you go all the way back to PDP246 with Krina Patel, the episode was titled, I Hate Crack Teeth. And you know what? I still hate crack teeth. They're a damn nuisance. They're everywhere. And it creates major consent and if the tooth goes non-vital, that kind of conversation which no one likes. Now, years later, we did this epic episode with Dr. Lane Ochi, PDP175. Guys, you need to check these two episodes out if you want to geek out on cracks. But you know what? This episode really does a wonderful summary of cracks, not just a diagnosis, but the actual management. Should we be chasing cracks? Are fibers actually indicated? Is there enough long-term clinical data to support the use of fibers in crack propagation? And the age-old question of, okay, when should you actually intervene? And you know what? The most important one I haven't even mentioned yet, right? So Dr. Masoud, the way I got acquainted with him is on social media. I posted this image of a crack, a really nasty crack. And he said something absolutely ridiculous, right? He said that cracks have an ability to heal a bit like cracks heal in bone. Now, he said that because in this image I posted on social media, it was all about how I communicate cracks to my patients. And I say to them, look, when you have a crack in a bone, the bone can heal, it can regenerate, but a crack in a tooth can never heal. And patients seem to resonate and they understand that. But he was suggesting that actually cracks can heal naturally, a bit like bone. And so if you listen to the end of the podcast, you will see how that is actually possible. Hello, Protrusive. I'm Jaz Gulati, and welcome back to your favorite dental podcast. I've had a month in August, which was pretty crazy. I didn't do much recording of new podcasts. We're just like working on some of the older recordings that I had done. We've got a huge backlog as a team, which is a wonderful position to be. Guys, we are having so much fun creating these episodes. Thank you for everyone who returns to our podcasts, and of course, all the new people that find us. If you're not already, you need to join 5,000 of the nicest and geekiest dentists in the world on the Protrusive Guidance app. Go on protrusive.app, make an account. Your only requirement is you must be nice and you must be geeky. If you are those two things, you should come and join us to geek out, discuss, share challenges, share wins. It's a nice wholesome environment we've created, far, far, far away from the toxicity you get on Facebook. Now, in true PDP fashion, I'm going to give you a protrusive dental pearl. This pearl helps me when I'm decision making with my patients, and it's all about probing further into the history of the patient. And what I mean by that is when we have that patient and we're planning an extraction, let's say, the tooth has had it needs to come out, and we're trying to gauge, will this be a difficult extraction or not? Well, did you know asking them if their previous extractions were difficult is actually a useful indicator? An oral surgeon once taught me this, and I think it's true. People have certain features that make their teeth more difficult to remove, certain curves, certain densities of bone, and that's a useful thing to have in your history. Now, similarly, in cracked tooth management, it's good to ask the patient how they lost their other teeth. So if you see a patient and they lost some molars and premolars, you should ask, well, how did this happen? For what reason did you lose the teeth? And if they mention cracks as the reason why they lost those teeth, those other cracks which are asymptomatic, because 90% of cracks are asymptomatic, now you have a reason to be a bit more proactive and less of the wait and watch and more of the, well, let's prevent this from happening to any other teeth. And so those are two clear examples of how the patient's history, i.e. the complexity of the extraction and the reason for tooth loss being cracked, are useful in decision making for the patient going forward. Now, I'm actually very excited to get to the main episode. Honestly, this is such a beautiful, geeky episode with real, tangible clinical nuggets for you to take away. And before we start this episode, I just want to give a quick plug to our trip in Dubai 2026. So, Easter holidays 2026, we've got UK dentists and their families and some Aussie dentists who are going to go to Dubai to learn occlusion with me and Mahmoud. And why are we doing this? Well, it's Easter holidays, Easter vacation. I want to take my kids and my wife. We want to have some family-fueled fun in Dubai, but we want it to be tax deductible. So how are we doing that? Well, picture this. For those of us with families and kids and stuff, bring everyone along. We're going to make it a very tax-efficient holiday for you. And so we'll be learning occlusion from 9 a.m. to 1 p.m. for the 5 days. So it's 20 hours of hands-on occlusion. And the rest of the day is self-study. Go to the pool, have some cocktails while you think about occlusion. Go enjoy the nightlife of Dubai while thinking about occlusion, of course. And really, you get to just enjoy most of the day with your family or with your friends in Dubai. And it's just the morning part where we'll do the education. Now, you also get access to a lot of online content and pre-learning. And we actually genuinely want you to come out having learned occlusion to a very high standard. But actually, I'll be honest with you, this is about the education, but it's also about having a good time in a tax deductible or tax efficient way. So if that's piqued your interest, I want you to go to globaldentalevents.co.uk. That's globaldentalevents.co.uk. Like I said, you don't have to be from the UK to come to this. We've got some interest in Scandinavia. We've got some bookings from the UK, dentists and their families. We've got some Aussie dentists coming along. And we don't need massive numbers here. We just need enough so we can put on a good show, but also we just need enough people to have some fun. This is actually a not-for-profit course. Me and Masoud are not doing this for profit. We just want to have a jolly with our families. And that's straight from the heart. Anyway, I'll put the links in the show notes. You are going to love this episode. Catch you in the outro. Dr. Masoud Hassanzadeh, welcome to the Protrusive podcast. You are speaking from the Netherlands right now. It's so good to connect with you. Let me tell you and everyone how we ended up on here. I posted something about cracks on social media, and you said something so mind-blowing, so fascinating, that I was like, okay, I need to speak to this guy, okay? So do you remember what you said? You mentioned...
I know,
right?
I know.
You said we can heal cracks like bone, okay? And so we're going to have to go there eventually, right? Because I'm really fascinated by... Obviously, there's a bit of a tongue-in-cheek there and whatnot, but I'd like to hear what's the best thing we can do for cracks. Many years ago, I did an episode with an endodontist, Rena, who's wonderful. We talked about how much I hate cracks, because when you have a crack, there's so many different ways it can go. The patient can become symptomatic. You need to have a lengthy consent discussion with the patient that we don't know how this tooth will react. We don't know if it can be saved or not. But there's so much we can discuss. And I really want to get into protocols and decision making and the different philosophies of managing cracks. So before we start with all that good stuff, Masoud, tell us about yourself. What are you doing in the Netherlands?
Now, I'm a dentist. I'm in the Netherlands, and it's about 4 or 5 years that I have my own dental practice. And yeah, I like restoring the tooth, and the crack was the first thing that actually I didn't know what to do. And when I asked other colleagues, and they say, yeah, I also see them, but yeah, you can maybe put the primer bonding on it, just flowable. And then someone say, yeah, you can put fiber on it. And but it's just confusing. And there are a lot of controversies. Some say, yeah, you have to pull it out. And especially when the patient comes for small restoration, they said, okay, sorry, the tooth, this tooth is gone. I saw a crack, but it was really hard for me. And I just tried to do my best for the patients to save the tooth. And I thought, okay, this crack, it should has a philosophy. It should has a way of restoring of it.
So like protocols to go by based on the level of diagnosis. I mean, I think there's only one thing that for sure we can agree with cracks, right? One thing, okay? And you tell me if things have changed, right? But if someone has a true split tooth, i.e. the fracture's going all the way through, obviously that's for the bin, that's for the forceps, okay? So that's one thing we'd agree with. And then also, if like you have like 5-6 millimeter probing depth associated with the crack, that's hopeless prognosis, right? Unless we're, let's be beating around the bush, that is hopeless. And I think most of us, we get that. And I think we understand that. But then there's that gray area where the crack is 1 or 2 millimeters subgingival. Or the other gray area is at what point do we intervene? Like we have an MO amalgam, and on the other marginal ridge, we have a crack. And this could be with staining, without staining, certain widths, certain durations. It's been there for 20 years. And so knowing when to intervene for a crack is something I'd love to talk about with you today as well.
So the first thing is not just we have to know the depth of the crack and where it is exactly. Is it an enamel? Is it in dentine? And the second point is the age of patient, because after age 40, 45, crack can unfortunately propagate very easily. And all of the fracture cases which you see, most of them are elderly patients. They are not young patients. If there is a trauma, that's another scenario. But these two things, especially the anatomy of the tooth and also thinking about crack repair, self-healing mechanism is really important for our decision-making for a treatment. And also about the post that you shared, that was a huge crack. It just starts from dentine and goes to the deep start from enamel, goes to the deep dentine, and you see
Masoud, can you remind me what my post was? I generally don't remember. What was it?
Really? Yeah, it was an amazing image of a crack.
Was it an extracted tooth in the crack?
No, it wasn't extracted tooth.
Okay.
It wasn't extracted. It was just, I think, intraorally you made the picture.
Okay, like an MOD black crack running through like that.
Yeah.
Okay, got
And
it.
the initiation part was really open. You see you see just debris and plug inside the crack. And
Let me see if I can pull this up because I a protrusive guidance audience and YouTube audience, it's nice to have a visual. For those who are listening, of course, we're going to describe it very clearly. And so it's a nice little starting point to discuss this one scenario. Yeah, that's an awesome image. Okay, so that's a power of sandblasting, right? So when you sandblast a crack, right, when you aerate a crack, like you can see it, and then I take a photo and I share my patient. So this post was all about how I communicate cracks to a patient. And so for those who are listening on Spotify, Apple, if you're chopping onions or excising, it's just a really nasty crack when you remove an MOD amalgam and then you aerabrate it and you literally see the white aeration powder track all the way. Yeah. So this is a very nasty crack, absolutely.
And yeah, you can see that this part is actually open and your sandblast particle is just, how you call it, it's just...
it's jammed, it's trapped in there, right?
It's like trapped there, it's just
so it's like you can, this is, but by open you mean we can feel it with the probe basically, like we can actually feel...
Yeah, so these are actually huge cracks, and it is really hard to make a decision in this point. What are you going to do? Are you going to remove all this healthy tissue here to overlaying that? And are you going to chase with the crack? Are you going to follow it? Why? Why should you follow a crack? And I think these are very important questions to answer it.
Sometimes you're looking like the patient's got like this non-specific pain. You're like, could it be a crack kind of thing? And a point you mentioned before we hit the record button, we only start noticing cracks when we wear magnification and we look really closely. Otherwise, we're like oblivious, right? We really don't see these very obvious cracks, but because we're not wearing magnification, we don't see it. And I also see everyone saying since COVID, we're noticing so many more cracks. Well, I think you're right. What you said earlier. Can you just say what you said earlier about how we're documenting better and stuff?
You know, it's just there are studies about just 8 to 9% of the cracks are symptomatic, like pain and biting or cold sensitivity. The other ones, like the 80-90%, is just asymptomatic. So we just see them during restoration. And nowadays you see on Instagram, like the image that you shared with high quality photography, with magnification, with microscope, and with good images. Most of the time, the crack is the first thing that we notice. And it doesn't feel good. Everyone said, something goes wrong with this tooth, you know, you have to do something. And you can't just put your adhesive system on it and just putting the composite or making a beautiful overlay on it. And if you also check the other posts, when there is a crack, there are always the comments, and how about the crack? What do you think? What's the prognosis? And what do you expect from your restorations? And these are the things that you start to think. When I start to learn about cracks, actually, the studies were not from dentists. They were fracture mechanic engineering, that they just studied about the crack. So they had a tooth and they just start to break it and they
like flex it, load it,
see the strain and stress on the tooth and how it's going to break. And they gave us a lot of information about crack initiation and also crack propagation on a tooth. And we also have some good studies from dentists. They try to treat it in different ways, especially the crack, and sharing their follow-up after 5 years and 10 years, and which restorative restoration is just the best, or restorative manner of the tooth.
All these answers to be revealed in this podcast, I hope. So let's start with the basics, okay? So one of my mentors, Lane Ochi, taught me that cracks in enamel are not so worryful. Cracks in dentine are the ones to worry about. So sometimes, let's say you have a lower molar, first molar, it's got a DO amalgam, and on the mesial, you see a crack, okay? Now, we see the crack obviously in enamel, and it could be stained or it could be not stained, but how can you be sure whether it's actually, you know, without removing the amalgam, how can you be sure if it's only in enamel or is going through the dentine?
It's hard. Maybe with transillumination, and they can give us. And nowadays, there is a new system. It is called quantitative percussion diagnostic. QPD, quantitative percussion diagnostic. So they are
Okay.
giving a very small percussions to the tooth, and they have a AI information. Like if the percussion is 100, then it's good. But if it's come 80 or 70, then there is a gap. There is an opening inside the tooth. It
It's
can
kind of
be,
like when you test, I don't do this, but when you test an implant for integration,
yeah,
it gives you
that's
some
it.
data. Oh, that's so cool.
The same system as it would, but it can be also because of a gap in a restoration. So if there is a gap, the
Okay.
information will change.
False positive.
Yeah, yeah. So the first thing is still crack or the gap, and but it is really hard. So always in all the articles, the first recommendation is removing the existing restoration.
Okay, I think that could be aggressive because like there are some guidelines. For example, if you see a crack, and obviously, like you said, 90% are asymptomatic, but if it's not stained and you can just about see it with magnification, but you can't see it with the naked eye, then maybe that's gonna be okay. But when it becomes stained, and then at that point we know that it's big enough to allow stain particles and bacteria to go
Yeah,
through. And so that is one thing I've seen cited in the literature, that okay, if it's stained, but you know what, Masoud, my patients in their 60s, they all have
yeah.
if we chased every single crack, like literally we'd be saying like 2 patients a day, and that's all. That's how I say to my patient,
Not
like, you have cracks.
cracks, tooth
Exactly.
cracks. It's just the crack belongs to tooth. So we have to know which crack when we have to intervene or not.
Mm.
And another point is use of fluorescence filter. Fluorescence filter shows us where bacteria are. So if you have a crack, you doubt, you can just put the fluorescence filter. And if
This is black light. This is like a UV torch, right?
it's not UV, it's a fluorescence mode. You can have it on
Oh,
your microscope.
fancy microscopes.
Yeah, yeah. Or there are also cheap ways, like in your loop, or you can just have an extra oral light and then just check it.
Okay.
And if there is a bacteria, the byproducts of bacteria becomes red, and
Mm.
in this way you can see if the crack is red or not, or is the bacteria biofilm in the crack or not. I just also shared some
Mhm.
posts about it,
Okay.
how you can check it. And that makes it easy to check the cracks, and then you can start to remove it. There is also a study from I think Rikuchi, and he says when the crack is connected to oral environment is actually filled with bacteria and biofilm, especially
Mm.
if the crack is in dentin, because dentin is more flexible. It can
Mm.
open and close, so there is a space for the bacteria to invade.
Mhm.
When it is in enamel, it's more rigid, it's more hard. So the crack faces are mostly they're just touching each other. It is called closed crack. So in that
Mhm.
way, there is almost no space for bacteria to invade inside the crack. That is also one of the reasons that we're not removing the cracks in enamel.
But like you said, it's difficult to tell. But okay, let's look at some metrics then. So some clues. Okay, so some clues could be that the crack is stained, that we're going to use the fluorescent lighting, see if there's bacteria inside. But we also have to look at the patient, right? Like if they've got big, strong muscles, if they've got a history of losing teeth before due to cracks, that is a very significant prognostic factor for me for should we treat this asymptomatic tooth or not. Is that if they've lost teeth due to cracks before, this is a really big deal. And of course, if the opposing tooth has already been extracted, then that
Yeah,
crack is not going to propagate. So you don't need
no,
to worry about that. So you have to remember that this crack is in the patient's mouth, and look at the patient as a whole.
yeah, that's right. I had a patient that she just broke the second upper molar, and there was no restoration on it, and it was just fractured. And
Yeah.
after 3 or 4 years, I saw a vertical crack on the other second upper molar, and they said,
Hmm.
"Yeah, we have to do something, otherwise you're just going to miss this one." And indeed, just like a big muscles,
Big masters,
masters,
high force patient. These patients I've seen, I remember seeing quite a few. I document these cases really well because it always fascinates me. And when I get that a few times a year, I see a first premolar usually or a second molar with a virgin crack without
yeah,
any restorations, and they come in irreversible pulpitis, right? And
yeah.
like it's like, whoa, what's going on? And then you're like, okay, and you start drilling into the tooth and you see his crack opening and opening and opening, and it's just fascinating. And they all have this thing in common whereby either their premolar is very cuspy. The angles are very acute in their premolar, and that you can
Steep
imagine that's
cost.
lots of
Yeah,
flexing. Exactly,
yeah,
steep cusps. That's been a risk factor I've noticed. And the other one is, of course, these clenches, these high force patients with large muscles, because muscles matter, right? These force transmission will be different for each of these patients.
Yeah, and also their distance to TMG, because there is also a nutcracker effect, and on the distal side of the second molars, upper and lower, we always see a vertical crack. Usually, if the patient is like 50, 60 plus, just make a picture intraoral image on it and just put it in the document of the patient. It's always there, and and also the upper premolar, because of its position, its anatomy, and it's just always going to break like vertically from the frication stress plane, just between.
We often see the palatal cusp completely come away, and then when you take that fragment out, it's like you see 4 millimeters of root come out with it, right? And I think all dentists have seen this, right? We all have that a few times a year, and it just gives us another reason to remember that, okay, just because it's asymptomatic doesn't mean we should just leave it. We need to make a timely intervention. So let's circle on this and make some clear guidelines for dentists. Masoud, when should we be intervening? What's the best evidence that we have so far about intervention? Obviously, we spoke about patient factors, the muscles, the history, the anatomy of teeth, but any other guidelines you can give? Okay, intervene when this happens.
The first point will be just symptomatic pain on biting. It is called rebound pain because the fragment is just going to move, and dentinal fluid is just going to fill the gap. So when during unloading, the fragment will just come very fast and it will just cause pain. So if it's symptomatic, it should be treated because it shows that the crack is propagating. The second one is also cold sensitivity. It can also be a same reason. And the other one are all dentinal cracks, especially if the patient is 40 plus, because dentinal cracks are structural cracks and enamel cracks are non-structural cracks. So if the patient is 90, there are a lot of the cracks in the enamel, we don't need to treat them. And if only the patient wanted to have a good aesthetic, because the crease lines can just get stained, become black, and maybe they just don't find it any not beautiful that much. But the dentinal cracks, they are structural cracks and they can propagate. And and the reason is in its anatomy and also in its histology, because dentin has its own mechanism to stop a crack. It's not like dentin has no mechanism and just the crack can just go, because these cracks can be there for 10 years, 20 years sometimes. And but the dentin can just, it has its own mechanism to stop the crack. But at the point, it's not working anymore. And the reason is when the dentin tubuli is just become close, and it is called sclerotic dentin. And all the collagens work together to creating crack bridging to stop crack from propagating. But the collagens, when we get older, they are like gluing to each other. It is called cross-linking. So in that way, the crack can just propagate more easily. That's the point. But when there is a crack in a young patient, he or she is not 40, I will not remove it. And I will also check if there is a bacteria or a plaque inside it. But if not, I will just leave it there.
Unless, and so I love that you said that. However, I had this 19-year-old patient. She's now 23. But when I first intervened on her, she was 19. And because she had that first rule that you said, she had symptoms. So this is a high force patient. Very rare to see a 19-year-old high force, huge masters, right? Destroys her Essex trainers in a year kind of thing. Now she's wearing appliances and it's taken her 3 years to destroy that. Virgin crack in a molar, symptomatic. And yes, when I traced it, and you can see the crack beautifully. And then once I restored it with a class 2 composite, because actually it didn't warrant anything more than that. Okay. And then the similar thing happened a year later, the symptomatic on the left symmetrical molar, and now things have been stable for some years. But as a rule of thumb, yes, young patients' dentin can probably handle it, but there are, times where it may become symptomatic in that case, and then we need to go case by case, I think.
Yeah, and I think in that way we also have to remove the reason. What was the reason? Was it bruxism? Was because of the anatomy of the antagonist or the tooth? And because there is a stress concentration in that point where the crack is starting. So we have to distribute the stress in that place, in that plane. That is the important one. If we're just going to remove the crack and putting the restoration on it, it's just I'm afraid it's just going to happen again.
I love that you said this, and I'm nodding. Like for those who can see in the video, I'm nodding. Because so what we had to do in this patient is, so she had like these crazy weft sets, right? And so I had to do a dirty thing. I had to do some adjustment. I had to do some selective grinding. This is force modulation. This is like we might be removing microns of enamel to save millimeters of dentine and keep the teeth going as much as possible. I had to, and so instead of having the occlusion on a very steep incline, I had to flatten it a bit to make sure the stress distribution is better. I had to, this plunger cusp type on the opposing, I had to just reshape it so it's a bit more gentle. I had to remove a very steep incline and flatten it. And I'm so glad you said that, because if you just replace it like for like, it will also have a marginal ridge fracture, which this one did, a tiny little marginal ridge fracture, which wasn't a big deal, but it just goes to show that you have to do some sort of force modulation.
Yeah. Or maybe using night guard.
She does. Yeah.
She's a praxis. Yeah. And I think also the final restoration is really important. There is a recent study from 2021 saw if the modulus of elasticity of the final restoration is close to enamel, the crack underneath will not propagate. It will just stop propagating. So when you're restoring with the composite, your modulus of elasticity is about 20, 22 maximum, but the enamel is about 80. So if you use a restoration, like a ceramic restoration, gold with gold, they also got good results. And I don't know if it would be possible to share also these studies. I can just send it to you.
Oh, please. Our colleagues love to geek out the studies. So send as many over. We'll put it like a downloadable document.
I would just send it to you. And they saw, so they restored the crack tooth with different kind of restoration, and they just checked when the crack is not going to propagate. And they saw it's happening when the modulus of elasticity of final restoration is close to the enamel. So actually the biometric concept that just restore, just try to mimic the nature.
Like lithium disilicate, for example. So I mean, in that specific patient, she was 19, man. So I did a direct. But yeah, if she was a bit 20 years older, I would have gone for my usual protocol, would be, good bonding under rubber dam with lithium disilicate, and maybe even at that stage be a bit more in terms of capping cusps where appropriate, and we can talk about that as well.
Yeah, because the form of the cavity is also important. Like in young patient, most of the time the cavity is not that huge. There is no place for indirect restorations. If it's a small class 1 or very small class 2 cavity, I would just also go to the direct composite. But in huge restorations or multiple cracks, most of the time they're just following each other. And you see like multiple cracks in one tooth. And in that way, I would just, I think we have to choose the final restoration very clearly, very good final restoration.
So gold is approved, makes sense, and good bonding with ceramics. Are you including zirconia in that?
Actually not, because zirconia has very high modulus of elasticity. It's about 200 gigapascal, and the enamel is about 80. And that is one. And the second one is just like the bonding, because you lose your bonding strength in zirconia a bit faster than in lithium disilicate. These are the reason that I'm not using zirconia. I'm using mostly lithium disilicate. But I see also dentists, they are getting good results with the zirconia. And I understand it.
Okay, fine. So we talked about which cases to intervene, why to intervene, why most of them are asymptomatic, but you got to pick and choose the ones where it's more likely to be in dentine. Look at the patient as a whole. Let's talk about operative procedures, right? Chasing cracks. So back in the image that we shared, to what degree should we chase cracks? Because if you keep chasing, you're going to hit the pulp, and then you're going to do an endo where you could have avoided the endo, obviously, right? So that's an easy one for us to understand. But are there any clear guidelines to how much of, we have caries removal endpoints. Do we have crack removal endpoints?
That's right. Yeah. If it's a non-vital tooth, I would just remove all of it if it's possible, And if it's a vital tooth, I would just save the pulp. I will not expose the pulp. I would just do my best to not expose the pulp. I will leave the crack on the center part, and I will put fibers on it. But in the peripheral zone, I just try to remove it. But unfortunately, most of this crack is just stopping at bone level. So it means that you have to deal with a very deep margin elevation or very deep margins. And these are really hard to get a good adaptation between the matrix and the margin of the tooth. And
Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
It's really deep, it's really dark, so you have to be sure that your light is just going there for polymerization. And most of the time, they have a really high C factor, because it's just like a tunnel, and there, a very narrow tunnel, so the composite is just going shrink, I think, very badly. So these are things that we have to think about it. Just try to minimize the C factor or the shrinkage stress, and to know that we have to deal with the very deep margins. But the first reason that this is the reason that I'm going to remove a crack, it will be just, it has a connection with oral environment. And if there is a plaque there, it will just go invade inside the plaque. That will be the first reason. And the second one will be just crack propagation. Because crack tip has the most stress there. There are some studies, they shows like finite element analysis. If there is a crack, the crack tip is just red, like all the stress is just there. So it will just propagate. And we just removing it, I can be sure that it's not going to propagate anymore.
I think to add to that, Masoud, thanks for that lovely commentary. I think to add to that, I would say, I went through ebbs and flows of chasing cracks, not chasing, not chasing, because I hear both camps. I hear what they're trying to say. I think whenever there's like two extremes, you have to go down the middle, and your answer is somewhere down the middle, right? And so basic things like if you got a crack on a marginal ridge, if you don't at least address that crack, then that's where you're going to get caries. And okay, it just makes sense. Okay, so and also you need to have access to your burr, access for your matrices, that kind of stuff, right? So that interproximal bit has got to go, right? The proximal wall. Then you got to look at biological limits, pulp being one, but also connective tissue being the other. So kind of like how we don't go into the pulp, the crack will get thin enough, and you might accept, okay, now the thinner, the crack is thinner, and I'm not going to chase this anymore because it will compromise the restorative seal or result that I can get. And the other thing to consider there would be when you are chasing these cracks, the most important part of the crack, yes, is the tip. Like you said, that's where the energy is. But if we can reduce the height of these cracks, right, we reduce the energy that goes to that tip. And so I think if you follow those principles of making the cavities cleansable, restorable, preserving pulp vitality, I think that's a good middle ground to go.
Yeah. So if I also adopt and I can't remove it anymore and it is white crack, I'm also stopping. And sometimes it's so deep, like my burr is not going to remove it anymore. I can't touch it anymore. And the good point is, this is like thanks to the study of the engineers, when the crack is in root dentin, is not going to propagate that fast. Crack in coronal dentin propagate faster than in the root dentin, and this is really interesting.
I didn't know that.
Yeah, I also didn't know that. So when it's on a root dentin, it's just not going to propagate that fast. And I will also share this study. I use all of this in my book. And yeah, when I read it, I was just, wow, this is mind blowing.
Well, let's go to that thing then about healing cracks. Okay, so you have that scenario, right, where you've removed the height of it, you've cleared away the caries, you're now not going to expose the pulp, and you've like reduced the height of the, you're maybe going to cap some cusps, okay, remove that couple of minutes of the cusps to, again, make it lower in height so it's less flexing. Makes sense. Okay, that's all something we can follow along with. But then at that point, how can we wave that magic wand and heal the crack like bone? You said we can heal the crack like bone. So what do you mean when you said let's heal the crack like bone can heal?
Yeah. When I read it for the first time, I was just, wow, is it really possible? But it is possible. Like how there is a crack healing mechanism in the bone, there is also crack healing mechanism in the tooth. The difference is the crack healing mechanism in the bone is just because of it's called regeneration. Like you have a multi-step physiological process, inflammation and hematome formation, bone remodeling, and at the end regeneration. And it is because of the blood supplies, because of the blood vessels there. But in the tooth, in dentin and enamel, we don't have blood supplies. We don't have blood vessels, only in a pulp. But interestingly, there is a crack healing mechanism in the tooth. It is different in dentin and also enamel. So knowing the histology and anatomy is really important. And the studies also shows it is different in inner enamel than outer enamel because of the inorganic and organic matrix of the enamel, hydroxyapatite, the protein. The crack healing mechanism is different in inner enamel and the outer enamel. The first study is from 1949. It is, he called Sagnus, 1949, and he thought the enamel tufts are actually cracks that getting healed. And then he saw, no, it's just hypocalcified intrinsic defect. And after that, in 1994, if I remember the name, Hayashi saw that there is a mineral deposition inside the crack, especially enamel cracks. And these are medial cracks on the occlusal part of the crack, and there are mineral deposition inside the cracks. Young, in 2009, he saw even the protein-rich fluid can go to the crack, and it can cause adhesive interlayering. It means like two crack faces is just going to glue to each other because of the protein-rich fluid. And in 2013, Ferra and Arola, it is an engineering group, saw even that the length of crack is just going to increase because of the healing mechanisms of the enamel, of the crack. And
increase the crack length?
Increase the crack length. Yeah, they shared this SEM images on their study. And that's really amazing. And they all works with redemineralization of the enamel. So because of the ion transfer, because of the protein, And also the protein, like the organic part of the enamel, which is close to the dentino-enamel junction, when there is a crack, they start to create a bridging, which is called crack bridging. This is only in inner enamel. And these proteins are amelogenin, ameloblastine, and enamelin. These three important proteins. And on the other side, so there is a fluid diffusion or infiltration inside the crack, and the cause just the crack is just going to be closed crack. This is why it's important to check with the fluorescence filter. If it's a closed crack, if it's a healed crack, there should be no bacteria inside the crack. But there would be enamel cracks which will be just filled with the bacteria and with the biofilm.
Okay, but I didn't understand the point about the crack length increasing. Surely the crack length increasing is a negative thing and not a good thing.
It's a good thing, because if the crack is about like 1 millimeter, now it's become even smaller.
The crack length
decrease. Decrease.
Okay, fine.
Decrease.
Okay, I'm with you now. Okay, now it's making sense.
All the sentences.
No. It's okay. It's good to clarify, right? And it shows you that I'm listening, I promise.
Okay.
So yeah, crack length is decreasing. Now I get it. Now I'm totally on board
Decrease.
now. Okay, so before we move on to dentine, you say all these wonderful things, but this is all just happening with saliva and the oral environment, or is there something we can do as dentists, because we like to do things? How can we accelerate this? How can we create an environment conducive to enamel crack healing?
That's a good question. You know, when there's what's the important point? It is saliva. So be sure that your patient has not a serostomy or stress and reduce the saliva. And that is the important part. And after that, actually, it is starting from the first moment that there is a crack. And after 48 hours, they started to see that the crack is just decreasing, like it's just healing. And can I share that study with you? There is an amazing...
let's talk about it.
They made also, see it?
Yes, Masoud has pulled up a paper. It's called Indentation Damage and Crack Repair in Human Enamel. So it's legit. He's not talking out of his ass. He's being honest, and this is cool. This is the geeky stuff we like on here.
Look at this.
Yeah. So we're seeing the crack length decrease after 48 hours. But this is in vivo, or this is in vitro, like they extracted tooth?
Yeah, this is extracted tooth. This is extracted. Okay. Yeah, they don't have it.
Of course, you can't measure that.
No, I think intraorally, if they want to see, we have craze line and we have internal craze line. And I think it would be possible to see that the internal craze line is just going to get repaired, like they're just starting to get removed and like disappear.
But there's really nothing for us to do. There's no like special toothpaste. There's no thing so it's just good to know that human enamel can have these self-repair mechanisms as long as you have a healthy patient, i.e. good saliva.
Yeah. And also if we have a healthy pulp, because interstitial fluid has also effect on crack healing. And crack can propagate if it's dehydrated, like in endodontically treated tooth or when there is a serostomy. So it's really important to keep the pulp vital.
Yeah, I mean, that's what they say, because it becomes brittle. And then, all the chemicals that we use for root canal and everything, the tooth itself, we all know when extracting a root-filled tooth, it just feels different, feels more sclerotic, feels drier. And so that's got to have something to do with it, of course. Fine. And then are we going to talk about, like, is there any healing mechanism in dentine?
There is also the healing mechanism in dentine, and it is also remineralization. And the other point, very important, is the collagen matrix. The dentine is filled with the collagen matrix. And this collagen matrix is like a scaffold for ions, for phosphate and calcium to just come inside the crack. The problem in dentine is because it is flexible, so the crack is just opening and closing. And that makes it really difficult for crack healing mechanisms. And if the patient is old, or 40 plus, so the tubule becomes closed, so there will be no interstitial fluid to to remineralizing. And also the collagen matrix will just start to glue to each other because of the cross-linking, so there will be no scaffold for the ion transport. That will be the problem, I think. But dentine has also its own mechanisms for get repaired.
But there's nothing we can do to promote this bone-like healing.
No.
And obviously,
like
most of the cases we see is too late.
image you shared, there is no mechanisms there. It's really over.
Well, let's talk about that right here, because you mentioned fibers. I don't use fibers at the moment, but if there's enough good clinical long-term evidence, I will be, of course, I will join the party. So you sound like you use fibers over cracks, because you mentioned that.
Yeah.
Okay, so to someone who's never used cracks, who's never really done it justice by looking into it that much, I'll be honest. What's up with that, man? What are fibers doing? Is it robust enough? Is it strong enough? Do we have any good long-term data that the cases managed with the fiber versus the cases managed without fiber? Obviously so many different variants, and you can't control for what the patient eats and clenching and that kind of stuff. But as a whole, where are we at with how far into its acceptance in the literature and acceptance into widespread practice we have these fibers, which we so nicely see on social media layering over these cracks in like a crisscross pattern?
Yeah. When there is a crack, there is a lot of stress there. So we have to do something. We have to redirect the stress. We have to distribute the stress, just like it's not just going to concentrate in one place. And the fibers is the best way to do that, just putting the fibers on fiber on the crack. In a vital tooth, the best way is just laminating, like putting one piece of fiber on it. And on an endodontically treated tooth, the best way is just annealing, like in a circle form of shape inside the pulp chamber. Mm-hmm. There are two types. We can use glass fiber, or we can use like a polyethylene fiber, the rebone. Mm-hmm. And it's just about like how are they bidirectional or unidirectional, and like the fibers like rebone, we have to pre-wet it. We have to make it ready to use. It's not ready to use, but the glass fibers are mostly just treated. They are just ready to use, and we can just put it on a crack or where we want. Mm-hmm. And we can use fibers in dentistry in three ways. Just strength restoration, like if it's a huge composite restoration and financially make it a bit difficult for patient to pay for indirect, you can put fibers inside your restoration. So in that way, you can strengthen your final restoration. Mm-hmm. We can protect the hybrid layer. The hybrid layer, the first minutes is just really sensitive to stress, like shrinkage stress. And with putting fiber on it, we can create a fail-safe protocol, like it's not going to fail it in that point anymore. And we can also strengthen the tooth, especially if there are a lot of sound tissue gone or removed, or especially if there is a crack, we can just strengthen it with the fiber. Recently I read a study. They checked the fracture strength of natural teeth without virgin teeth, without any restoration. And also they checked the fracture strength of a tooth with a crack. These both were premolar, upper premolar. The natural intact tooth had about 1,200 Newton, but the tooth with the crack was about 400 Newton. So it was 3 times brittle than, or we can fracture easier than the natural.
Fracture prone, yeah.
Yeah. So in this way, with the fibers, you can just redirect the stress which is coming to the crack.
And so do they have any such scenarios where they take that premolar, now chase out the crack as you would do, right? And then put the fiber on it, and then restore it, and then put it under the same loading? It would be nice to know how many newtons it can take now. We'd expect it to be more?
Yeah. It's about 3,000.
What?
It's about 3,000. You make it stronger than a natural tooth.
No way. Okay, you have to send this paper. You have to send this paper.
I will share it.
That's pretty cool. Okay, that's pretty cool. Yeah. Okay. There is process-based reasoning and there's outcome-based reasoning, right? And so process-based is like, okay, by doing these fibers, by doing this, we're strengthening the tooth. But what we care for more is outcome-based reasoning. So for example, because we did this, my teeth are lasting 30 years, whereas before they were lasting 20 years, right? It's like we're doing this more complex thing at an added expense, added time. There's more risk involved in terms of you might mess it up or whatever. There's more the time consuming and stuff as well. Whilst that sounds awesome, right? Where on the benchtop we can get that data, and I think that says something. That's pretty cool. I didn't know that, right? And I think there's a lot of things in dentistry which we look at, we don't have any clinical reasoning for, but it makes sense in a physics way, and a lot of occlusion is like that as well, right? A lot of the adjustments I do are based on that, so I'm not averse to it. But it'll be nice to have any clinical data to support how it may be superior, and therefore it can justify the added expense in terms of time and materials to a patient. Where are we at now in terms of waiting for that kind of data?
Yeah, not really that much. Endodontists, they are sharing more cases, more follow-ups, especially in crack removal. One is Philipson, I think. I also had contact with him for writing my book, and he shares like with removing the cracks, he see that the teeth are just going to live for 10 or 15 years. And this is the way why he's supporting the idea of crack dissection. And he's dissecting the crack from 10 millimeters. He says, okay, after dissecting the crack, there is the solid pocket of from 10 millimeters. He's putting biodentin or MTA there. The X-ray is just looking very crazy. I will never do it, but he just want to save it. He just want to save it and show it. And he made very good studies, publications about it. It is really amazing to see how crack removal works. But in terms of using the fibers and long-term follow-ups, unfortunately, I couldn't find anything. The way we have about crown, and we have about cusp overlaying, like removing all the cusp and overlaying, and then you will see just a good results. We also have a study with crack removal, and I think it's an Australian study. It also shows in 5 years 10% survival after removing the cracks.
What do you mean by that? Sorry, 10% increase, or like 10% survival overall? What do you mean by that? Sorry.
Like they have the all survival, like they don't need to extract a tooth because of a fracture.
Okay. But what was the intervention that they were testing in that study?
In this Australian study, they just removed all the crack and they dissected all the crack. They were symptomatic tooth, and they made the restoration. Some of them, because of deep cracks, they needed endodontically treating.
So this is like going against what we said earlier. So me and you said, okay, let's not go over the pulp, and let's not go too far subgingival. You're telling me in this study they just went crazy. They went for it. No more crack.
Yeah, they just went for all of the crack. They removed all of it, and after 5 years, they had just 1% survival. No teeth were extracted. All was just in a tooth.
They had 1% failure. You mean?
They had no failure.
Oh,
they
okay.
had no failure. Survival.
Okay. They had 100% survival.
100% survival.
Okay, cool. Okay, fine. Okay. But then that's a very aggressive way. Then should we, based on what we're learning from that study, should we be adopting that?
Yeah, that's a good study. There are not that much study, unfortunately. Like in adhesive dentistry, there are thousands of study. When you search about the primer or boning, you will get a lot of stuff.
But in that case, you said they have to do endodontics, which makes sense. Like if you're chasing all the cracks, you're going to be doing endo more often than not, right? Because So again, I think as Pascal Magnier says, right, the root canal treated tooth will never win the Olympic Games of restorative treatment, right?
So unfortunately.
Well, whilst that's an interesting study, I don't think I would change my way of I wouldn't go to aggressive totalist chasing all the cracks. Would you agree with that?
Yeah, I will also not do it. No.
And 5 years, we need more. We need up to 20 years plus. We need to compare it to, is it better than what we're already doing? So yeah, I think you mentioned some great points. Masoud, you've answered all my questions. It was really fun to speak with you there. I would love for you to tell us about your book. You mentioned your book a few times. I've seen it on social media. Tell us about, because it's no easy feat to do a book. I'm doing a book at the moment. I know it's no easy feat. Tell us about it.
Yeah. This is my book, The Crack Tooth.
Oh, sweet. Okay. Is this a different one to the one that you had on? So
this is the one. I also published another one that was the Glossary of Biometric Restorative Dentistry.
That's the one I saw. Okay, that's the one I saw.
This is a new one from this year. This is only about the cracks in tooth and what we have to know about it, with all references at the end of each chapter.
That's amazing. Oh man, that's so geeky. I love that, Masoud. Well done. I mean, that must have taken so much time and effort. Really well done, mate.
Yeah, it took almost 3 years to do it. First, I had to study lot, and I had to make all the connection with the engineers. Actually, how does it work? I really didn't understand. Like, there is a Paris law in fracture, so in that way they can measure crack propagation. But the problem is they have continuing mechanisms. It means like point A and point B has the same physiological or has the same chemistry and the physiological properties, but in the tooth each half millimeter is just different. So it makes really difficult for the engineers to calculate the crack propagation, the real crack propagation in a tooth. So they have to divide to deep dentin, intermediate dentin, superficial dentin, inter enamel and outer enamel. And also with my book, my idea was just making a very small book at 90 pages to sharing with my colleagues, to sharing my information with them, but it becomes 400 pages. And and still they are studying that they are just making, and some of them I just read some weeks ago and I said, maybe I should put this study also in my book. But
Volume 2, that kind of stuff. Masoud, is this on Amazon?
This is on Amazon, yeah. It's on
All
Amazon.
Right. Please send me the link. I would love to share it with Protrusive. I think what you said was making a lot of sense. I think I like that. The only unanswered question I have is the very first few things you mentioned about the percussion-based diagnostics. Is that like a special tool you have to buy or what?
Yeah. It is called Interview. You know, the links are very interesting. The first dentist who called the crack in dentin is structural. It was David Clark. David Clark wrote a study in 2003 with challenge sheet, and challenge sheet invent this instrument. It is called Interview. So in this way, you can measure it if there is a crack in a tooth or not. I would just show an image of it.
I like the idea of gaining objective data. It's why I bought the T-scan and occlusion. I like the timing data, the force data, and this is another thing that can just help you, like transillumination. You're trying to like get more data of, should you intervene, should you not? I like that.
Yeah, this is really.
Is it an expensive toy, Masoud?
Yeah, I think it's about $2,000 or $3,000.
Yes, it's an expensive toy. Okay.
Yeah, $2,000 or $3,000, and it's not going to.
Is there an AliExpress version? No, I'm just kidding.
I don't know.
I won't check.
I know there is a first version. Another team just tried to make it, but it's not that much easy to use. And the idea of Interview is just you have a pen and you're just going to on each tooth and you can test it and you can see on your screen.
You're kind of describing like a tooth sleuth in a way.
Yeah, like that. But this one is just going to tap or sending percussion on a tooth and just getting the info back from the tooth. And it is now waiting for ADA approval from USA.
Okay.
And I think they are waiting this year or next year to bring it to the dental shops.
Amazing. Well, I think now that I know about this pricey device as well, this data is cool. I didn't know about that before. I didn't know that root dentine is more resistant to cracking. That was fascinating. I didn't know about the epic impact of these fibers on these extracted teeth. That's really cool to know. And I didn't know you had that book on cracked teeth. That is awesome, man. And I'll put the link there for everyone to check it out, to see all your hard work. Masoud, thanks for sharing so generously with the community. We really appreciate people like you doing the work that we don't want to do, right? All the hard work and reading, then sharing all the answers with us. We really appreciate you, man. You're the kind of guy whose homework we copied. Thank you so much, Masoud, for all your work on cracked teeth. And I will put all the papers that you send in the blog link. I'll put your Instagram. Please tell us about your Instagram.
Yeah, on Instagram, I started just with sharing normal things. I had just 100 followers. And then I started to share my daily challenge. Look, guys, this is the thing that I'm dealing with and I have to do. And now it's about 400, 500 posts that I made with the really difficult situations. And I always get good answers or good reflections, like feedbacks. Hey, you're sharing the things that I didn't know how to do it, and it's almost the same. Now I have more idea. And like with the last years, I just make all the images with the microscopes. They are 28, 29 times magnified.
Wow.
It gives more information. You can really see the mantle dentin. You can really see the inner enamel. You can see the outer enamel. You can see the histology difference between these two. Also, the dentino-enamel junction. And I also shape images with the fluorescence filter, and you can see where the bacteria are and where you have to remove. And not all the length of the crack is filled with bacteria. When it is closed crack, there is no room. Even in dentin, I share the case when I start to chase the crack, and each millimeter I just made the image with the fluorescence mode, and you see after 2 or 3 millimeters it's not red anymore. It's just clear, but the crack is still there. But so it means the crack faces are just so tight connected to each other, so there is no space,
So it's like the width of the crack is getting less, which makes sense, right? The crack would be more open at the top, and as you go more cervical, it would get thinner and thinner. And that makes sense.
It is called transition. We have three type of cracks. The one is closed crack. All the crack face is just connecting, like crack in enamel. Second one is transitional crack. And these are like the first point, the initiation point is open, but the close to the crack tip is just closed. And the other one is just totally open crack. And in dentin, we see most of the time the transitional crack, like the first point is just open and the crack tip is just close near the crack tip. And when it's open, there is just space for bacteria and biofilm to go there.
Amazing. Well, everyone do check out Masoud's Instagram. I'll put the link below. Masoud, thanks so much, my friend. Have a delightful Friday, and I can't wait to publish this. And I'll give you a shout out, my friend. Thanks so much.
Thank you, Jess, for your time, for invitation. And sorry for messing up a bit with the increasing and decreasing.
Oh, dude, it's totally fine. But I was thinking in my head, okay, when's the right time to intervene? And you nailed it, man. Thanks so much for a wonderful summary on cracks. Well, there we have it, guys. Thank you so much for listening all the way to the end. I know you want the papers. Listen, scroll down below if you're on Protrusive Guidance. They are all there. If you're on YouTube, check out the WordPress link. And again, we'll have them all there for you to download. The easiest way is to head to protrusive.co.uk/cracks. That's protrusive.co.uk/cracks. And our manager, Alex, she's going to actually zip all these papers that Masoud sent us and send them to you. And we'll also send you a link to his book on Amazon. I think it's amazing that he's done this. And if you want to geek out with him more, check out his book. I'll also put his social media. And of course, you can get CE for this, right? You've done the hard work. You've listened. You've watched. You can get CPD or CE credits. We are a PACE-approved education provider. The only way to get CE for this is on Protrusive Guidance app. You need at least the CE plan, which is amazing value. Like dentists are getting 100 hours of CE every year just from listening to the podcast while they're commuting and answering the quiz on the app. If you want to get the full fat version, you get access to VertiPreps for plonkers, the 21-day photography challenge, rubber dam, premium and clinical walkthrough videos. All that good stuff is on the Ultimate Education Plan, so check it out on Protrusive Guidance app. And once again, if you fancy coming to Dubai with us, it's globaldentalevents.co.uk. You click the button to kind of get a quote. You have to kind of say, okay, how many people are coming? Is it you and a spouse, or you and spouse and kids, or just you? And then you get some hotel options and flight options, that kind of stuff, and you get a quote that's going to be tax deductible because it's for work. Remember, we're going to learn occlusion and have some fun. So just globaldentalevents.co.uk. I'll put the link, everything you need in the show notes. And thank you so much for listening all the way to the end. Honestly, you guys, it means so much to have your listenership and engagement on all the platforms, including Instagram and stuff. So thank you so much. I'll catch you same time, same place next week. Bye for now.